Good morning, everyone, and thank you for having me here. I'd like to take this opportunity to thank Dr. Shona Nag and Dr. Sudeep Gupta, and it's great to be back here as a speaker. To begin today's abstracts on the second part of it, loco-regional breast cancer. The first is that of eliminating breast surgery for invasive breast cancer in exceptional responders to neoadjuvant systemic therapy, which is a multi-center, single-arm and phase 2 trial. Currently, we really don't have a proper definition of pathological complete response, but most commonly it's defined as the absence of residual invasive cancer on H&E evaluation of the complete resected specimen and all the nodes. And at a range of around 60%, most commonly TNBC and HER2 positive cancers respond the best. Retrospective and previous prospective studies studying the omission of surgery had varied methodology and contradictory results. The most common, the two studies, one from Hale et al. In 2016, studied the similar pattern of study in patients who underwent a neoadjuvant systemic therapy followed by an ultrasound-guided VAB followed by standard surgery. And the FNR of the representative sample in this study was 4.8%. In another study by Kruer et al. In 2017, who studied TNBC and HER2 positive patients who received NST, underwent an ultrasound or a mammogram followed by FNAC and a VAB. The FNR for that was 5%. However, currently, we still go ahead for axillary surgery, which is a standard of care. So the design of this study is that women above the age of 40 who are non-pregnant, unicentric, T1, T2, N0, N1, M0, TNBC, HER2 positive with a residual cancer of less than 2 centimeters receiving a neoadjuvant systemic therapy underwent an imaging with an ultrasound or a mammogram, followed by vacuum-assisted core biopsy of the tumor bed with a 9-gauge needle and at least 12 cores were taken. If they had a residual disease, they went ahead for surgery with radiation, if not just radiation. The primary outcome of the study was ipsilateral breast tumor recurrence. And also to note, the follow-up for this study was 6-monthly with a surveillance mammogram, and if there was any suspicious lesion, they would undergo a biopsy. Secondary endpoints were number of patients with a residual disease on final biopsy and the quantification on a surgical biopsy, number of patients for whom an image-guided biopsy was advised on a follow-up. So 50 patients were eligible, out of which 19 of them did not have a PCR, and out of those patients, 12 of them had a residual disease on the surgery, but 7 had only a residual disease on the vacuum-assisted biopsy. This 17 patients had a clinical complete response and 31 had a PCR in the breast. Amongst this 31 patients, on a median follow-up of 26.4 patients, there was no ipsilateral breast tumor recurrence in any of them. Follow-up biopsies to note. On follow-up, around 29% of them had biopsies. The author concluded that eliminating breast surgery in a highly selected group undergoing an image-guided vacuum-assisted biopsy, which determined pathological complete response, is feasible with promising results. However, in my opinion, although there are certain sets of patients who are especially TNBC and HER2 who have attained PCR, we don't know the exact biological, tumor, and pathological factors for this. And clinical complete response, because in this study, most of the patients who underwent a vacuum-assisted biopsy did not have a radiological complete response, we definitely need a pathological analysis of the tissue, which is very apt. Vacuum-assisted biopsy and TAD, targeted axillary dissection with clips, are not really practiced in India because of resource constraints. The follow-up of these patients, even though it's TNBC and HER2, is too short. And 6-monthly mammograms is not viable in terms of infrastructure, and the follow-up also would be challenging. And also note that the primary outcome was ipsilateral breast tumor recurrence, but adjuvant therapy in cases of residual disease in TNBC and HER2 positive patients, as from the CREATEX and the Catherine trial, will affect this, and that would be incorrect assessment. So to actually go ahead and use image-guided biopsy, it seems like an attractive option, but we will need more prospectively conducted trials. The second was the surrogacy of pathological complete response in trials of neoadjuvant therapy for early breast cancers, the critical analysis, strengths, weaknesses, and misinterpretation. So today, do we really have a definition of pathological complete response? It's debatable. And it's currently only being used as a surrogate by regulatory agencies and FDA for fast approval of new drugs. The collaborative trial neoadjuvant breast cancer pooled analysis from 12 identified trials, including 13,000 patients, showed that the eradication of tumor from both the breast and the lymph nodes was better associated with an improved EFS and an overall survival than breast alone. And those patients who are TNBC and HER2 positive had a better pathological complete response. But this was only at a patient level and not on a trial level. This study did not validate PCR as a surrogate endpoint. There was another meta-analysis by Kruer et al., including 54 randomized controlled trials, but that did not support the surrogacy of PCR in early breast cancer either, simply because the coefficient of determination of association was 0.08, which meant that 8% of the variability among the treatment's effects on the overall survival could not be explained by PCR. So what are the potential explanations for the limited surrogacy? One is that having an effect on the primary tumor does not mean that micrometastatic disease would definitely be targeted. The experimental treatment arm compared with the standard arm may increase PCR rate for patients with a sensitive disease who would already have had a good prognosis, whereas it fails to overcome resistance in tumors with a poor prognosis. Patients who do not achieve a PCR are not at a disadvantage as shown by patients in endocrine responsive breast cancers who derive an impressive survival benefit from endocrine treatments but rarely obtain a PCR. And post-surgical therapies, such as studies from the CREATEX and Catherine trial, can improve the prognosis of patients, particularly those who do not reach PCR, diluting the association at a trial level between PCR and long-term outcomes, which intrinsically hampers the use of PCR as a surrogate endpoint. There are studies being conducted for alternate surrogate endpoints such as major pathological response, residual cancer burden, and multiple surrogate endpoints such as PCR and RCB, but they're still being studied currently. And the most interesting amongst all of them would be biomarkers such as ctDNA, which are currently in studies. So the weak association of PCR in randomized controlled trials definitely limits its surrogacy to evaluate surrogate endpoint to evaluate long-term outcomes. Although patients who attained PCR showed good prognosis, this correlation was not seen at trial levels. That is, patients enrolled in trials have not shown this result, probably due to tumor heterogeneity or other related factors. However, the FDA continues to use PCR as a surrogate endpoint in trials, and this should be reconsidered. Let's wait for studies on biomarkers such as ctDNA as a surrogate endpoint, which seem promising. The third study is that of an intelligent vacuum-assisted biopsy to identify breast cancer patients with a pathological complete response after neoadjuvant systemic treatment for the omission of breast and axillary surgery. So in the era of multimodality management, there is a reduction of surgical interventions, especially in this era of de-escalation. And this does reduce the burden for treatment, a burden of treatment for the patient, provider, and funder. Intelligent vacuum-assisted biopsy is a multivariate risk model that uses machine learning techniques to analyze conventional VAB results alongside contextualizing patient, imaging, and tumor information. We don't really have too many studies on this, but there was a study done by Fobb et al. And using this intelligent VAB to identify exceptional responders. He tested 4 multivariate algorithms using data on 457 women and randomly proportioned the patients into training and test set. And these patients were stage 1 to 3 undergoing a vacuum-assisted biopsy prior to surgery. The best algorithm was validated in an independent 4th trial. In this study, in the test set, the FNR was 1.2%, and on average in the three trials, the specificity was around 55%. And the validation set showed an FNR of 0%, but the specificity was 65%. So based on this study, a multivariate algorithm can accurately select breast patients without residual cancer after neoadjuvant treatment. However, the axillary status was not integrated. So the design of this study was, it was a retrospective analysis of individual patient data or 2 prospective trials that evaluated the use of minimal invasive VAB to reliably exclude residual cancer in breast after neoadjuvant systemic therapy. And again, the inclusion criteria was similar, T1 to T3, N0 or N1 with a partial or complete response to NST, and TNBC, HER2 positive and high proliferative luminal B. The results of this VAB were compared to surgical HPE. The FNR and specificity were the main outcomes of this study, and a 10-fold cross-validation, here the 10-fold meant subgroups, was used to train and test the algorithm, and which was compared to the independent data by Hale et al. This was the algorithm and the 10-fold validation. The total number of patients were 318 in the test arm, and the validation arm were 45. The pathological complete response in the validation study, I'm almost done. The pathological complete response in the validation study was 44%, and FNR was 5.2% for intelligent web, which seemed attractive, but the specificity was 37.5%. And multivariate logistical regression showed patient age, lesion diameter after NST, HER2 status, progesterone status, and taking a good representative samples was significantly associated with the residual tumor. And on subgroup analysis, the FNR of intelligent WAB was highest for HER2 positive patients. So the author concluded that an intelligent WAB algorithm can reliably exclude residual cancer after NST, and the omission of breast and axillary surgery for these responders may be evaluated. But my comments on this are, although we are in a de-escalating era, do women with simple lumpectomy and sentinel node biopsy have a bad quality of life or worsening prompts to actually risk their safety? And we're also evaluating PCR as such as a surrogate endpoint, which is quite debatable. So can we actually use this to determine the outcomes of a study? Although FNR seems to be attractive, the specificity is 40%, which definitely has to be addressed. And for something like intelligent WAB to be used in this country, we have resource constraints, lack of infrastructure, and lack of transdisciplinary knowledge. We need prospective studies with stringent data, good collection, patient selection, and protocols with confirmatory evidence to use this in the future. Thank you.